interesting talk for you guys this morning. It is my pleasure to introduce Dr. Stephanie Martin. She's coming to us via Colorado Springs, right near Denver. I've had the pleasure of knowing Steph since, 2000 or so. So we've been friends for a long time, and former practice partners for about 6 years in Phoenix. Dr. Martin comes to us via the University of Dallas for college, and then at TCOM, Texas College of Osteopathic Medicine for, she got her DO. And, no. That's share a little love there. Share a little love. And she did her training and her fellowship at UC Irvine, so she's part of the Irvine Mafia that's there. Their reach is very far and influential. I've got to know Steph as one of the smartest people I know, seriously. And her special interest is in the area of obstetrical critical care, particularly in pulmonary and maternal and cardiac medicine and complications of moms. As a result of her passion, she has done things such as, well, she's, of course, obviously well published in the field of critical care obstetrics, and she's done several things, for example, on cardiac parameters of pregnancy. She also has done some interesting work in terms of approaches to managing morbidly adherent placentation as well. Currently, she is head of Southern Colorado MFM. She also serves as a board director or a course director for the American Board Review. And was a former board member of the Society for Maternal Fetal Medicine. So very accomplished outside and inside of medicine as well. I'm pleased to call her one of my lifelong friends, and I hope you enjoy the lecture. So please help me welcome Dr. Martin.
Yeah, Garrett was a great partner to have because he was like the calm in the storm. When we were both working in Phoenix, it was a typical day. We were talking about this last night, was rounding on about 60 or 70 patients, supervising the residents, the fellows, the students, and then covering deliveries and transports. We get on average about 3 to 4 transports a day, and lots of chaos and fun all at the same time. We're going to talk about sepsis today. So how many of you have had a septic patient within the last week? 2 weeks? 3 weeks? I had 2 last week. And so conveniently, right, as I was, looking through my talk, I get called, literally, to go see a patient at the hospital who is 26 weeks pregnant, flank pain, right-sided, not a surprise. She had been in the hospital for about 24 hours by the time I got called and had not yet been worked up for possible sepsis. She was relatively afebrile at the time, although she was spiking temps up to 103, had positive urine. It's not a surprise the patient had pyelonephritis. But what people were surprised to find was that her lactate level was 4.6, and we'll learn about lactate here in a little bit. And her blood cultures were positive for E. coli. She did well. After about 3 days of fluids and antibiotics, she was fine, ready to go home, doing well. And that's one of the good stories. I'll tell you a couple stories today. I'm not going to spend a lot of time having you learn details of protocols or what early goal-directed therapy means or anything like that. We're going to talk about concepts because we all look up these targets and these goals and these protocols. They're probably in your electronic medical record. So today I really want you to understand concepts and principles far more than memorizing specific protocols. This was a patient that I was involved in the care of, 34-year-old Gravida 1. She got admitted at 15 weeks with trichorionic triplet, IVF pregnancy, and PPROM. This was the result of her 4th IVF cycle, so you can only imagine, with no living children, so you can imagine the level of intensity that this patient, created around her. I mean, he just radiated off her. These were her admission vital signs, totally normal, nothing unremarkable. She was started on broad-spectrum antibiotics. I have no idea why she had a cerclage in place. This was not my patient, nor my practice. This was another practice entirely, so I have no idea. And at this point, I was not involved in her care. That cerclage was removed the next day, thank goodness, and she's rapidly and spontaneously delivered triplet A. The placenta was, of course, left in situ. 10 days later, so she's about, 17 weeks almost, she has a temperature of 100.3. Now, in my next several slides, I kind of do a timeline here. And it's not to bash anybody, it's just to show the progression of events over time, because this is real life. None of this is made up. I don't have to make it up, right? So hospital day 10, she's got a borderline temp of 100.3. Her blood pressure's fine. She's slightly tachycardic. The next day, her temp is still 100.3, 3 in the morning, and so the nurse is concerned. She calls the resident who didn't do anything, or at least didn't document that they did anything. There were no notes, no residents, nobody, no orders, nobody came by to see the patient, no attending was called. An hour and a half, 2 hours later, her temp is 102.1. They order Tylenol. Now, if you leave here with nothing else, Tylenol is not a treatment for sepsis. It very successfully will make that pesky temperature go away so you can keep doing whatever you're doing. But it doesn't address the fundamental problem, which is why on earth does the patient have a temperature of 102.1 to begin with? About an hour later, the patient was evaluated. They did all the right things, ordered broad-spectrum antibiotics, did blood and urine cultures, and another hour later, the attending arrived and did an ultrasound and nothing else. No orders were changed, nothing else was done. Probably were waiting for the results of everything else. The patient was getting appropriate, antibiotics at that point. About 2.5 hours later, she's now shivering, but she's afebrile, and she gets more Tylenol. About an hour later, she's now febrile significantly. The attending was called. She gets more Tylenol. I don't know how she still has a liver. 30 minutes later, she's tachycardic. The attending's notified. Nothing happens. Later that afternoon, she's shivering. The resident's called. Nothing happens because my attending's been called 3 times. What do I have to offer, right? Except a complete physical examination, a reassessment of what's going on with the patient. And that night, the lab called. Now, how many of you have gotten a blood culture back in 24 hours with a positive result? Can you imagine the load of bacteria in this patient's blood that in 12 hours you've got gram-negative rods growing in the blood? I mean, that's poop in the blood. I mean, think about that. She gets moved to the ICU and I get consulted. This is when I become involved with the patient's care, and after I have to take my own blood pressure medicine and everything, then we get involved. When she gets admitted to the ICU, and the first time I see her, her blood pressure is 80s over 50s. Her mean arterial pressure is in the mid-50s. She's tachycardic. Fortunately, she was otherwise healthy, and so her lungs remained relatively unaffected. She never had a lung injury. She was tachypnic, however. She was not peeing. We put a line in everything we could put a line in, gave her more broad-spectrum antibiotics, and started aggressively fluid bolusing, and she would not allow me to terminate the pregnancy. We had many, many conversations. By the time I convinced her that the pregnancy was over and we really had to facilitate the delivery in order to allow her to recover, by that time I did an exam and the bag of water was already she was essentially spontaneously delivering, and she delivered very quickly after that. Triplets B and C delivered very quickly after that. She had to have a curettage for retained placenta. And in about 12 hours, she got 7 liters of crystalloid, 2 units of PAC cells, just to keep her blood pressure and her central venous pressure up above 8. We also had to put her on Levophed to keep her blood pressures up. So this patient, now this is one of those patients where everybody's like, oh my gosh, she got so sick all of a sudden. This patient was dwindling for a while and got sicker probably than she needed to be before she recovered. But she did well ultimately. She went home. I have no idea what has happened to her since and whether or not she's gone on to have other babies, but got lucky here. Now these are her labs. And I want to show you some interesting stuff about her labs here. So this is the day she was admitted here. All right. You can see her white count, pretty unremarkable. She's a little anemic. This is not shocking. She has triplets, even though it's early in the pregnancy. And then this is the day that everything started happening. Okay, I call it day 1 because this is the day that everything started, when she started having fever and symptoms. Nothing real dramatic here. Now, if you had drawn a white count on this patient at this time, she was febrile, we were concerned about her infection status. She's got a white count of 6.9. Any of you worried about a white count of 6.9? Why are we worried about this? Because of this happy little number right under here. 40% bands. Now, what are bands? Immature white blood cells. So what happens when your band levels start to go up? It's because your bone marrow is pumping out infection fighters so fast that they're have to sending out the new recruits before they're mature. So the higher the band level, the harder the bone marrow is working to actually make white blood cells. So this low white blood count is a problem because she's actually running out of white blood cells. That's what's happening. they're just being used up so quickly that they're almost half of them are immature forms. This is incredibly dramatic. Now, we'll talk about this a little bit, but this SVO2 is essentially oxygen delivery to the tissues, and this is not good. This is a little bit high. In other words, you want that number to be somewhere in that 70 to 80 range to show that when you're delivering oxygen to tissues, it's actually getting used. The higher the number, the worse it is, because if the blood comes back oxygenated to the heart, that means it's not being utilized appropriately. And in the case of sepsis, it's because it's not reaching the tissues. Now, if you're septic, why do you think oxygen would not reach the tissue level? Hypotension. And why do they get hypotensive? They don't have enough fluids. As evidenced by the fact that in 12 hours I had to give that patient 7 liters of fluid in 12 hours to keep her blood pressure up. Okay? So it's volume depletion. So fluids. Now, we're going to learn about lactate later on in the talk here, but then what you see is here she delivers, and look how rapidly things start to turn around. This is 5 hours difference, because the half-life of white blood cells is about 6 hours. So quickly people recover, and then look, very quickly she's got less immature forms and lots more white blood cells because the insult is gone. You've cleared the uterus. You're starting to get rid of the infection. That's called source control. Okay, so in non-obstetric fields, source control means taking out the infected appendix or the septic gallbladder or whatever. In obstetrics, it usually means emptying the uterus or treating the urine or the lungs or whatever it may be. This just got published. Like, literally, I had to pull my slides and update them because I got this on my desk the other day. The CDC does these statistics. It's about 4 years behind, but these are the causes of pregnancy-related death in the United States between the 2011 to 2013 period, and you can see infection sepsis is right up here. All right? Now, what's interesting is that it has surpassed hemorrhage and clot and hypertensive disorders. You see this? So we've got cardiovascular diseases, other medical non-cardiovascular disease, you can imagine what those are, and then here's infection and sepsis. Now, some of this is diagnostic. It's an artifice of just us getting better at coding, because this patient that I saw this week that had sepsis was not ever coded as sepsis until I got involved in the patient's care. So there are now moves afoot, and in many hospitals that have EMRs, the detection of sepsis is getting better because there are trigger criteria that warrant an official diagnosis and consideration. You have to actively say, yes, no, she has sepsis, she does not have sepsis. So our diagnosis of it is getting better. So some of this is capture, but some of it is, huge efforts to reduce hemorrhage and reduce clot and recognize sepsis more. This is HCA data published about 10 years ago now. I include it because it's a huge number of pregnancies, over about 1.5 million pregnancies. And you can see if you take obstetric and non-obstetric infection, they're right up there with preeclampsia and amniotic fluid embolism as causes of death. So we can't ignore this. In the non-pregnant population, sepsis is a killer. But people don't really think of it that way. They think of it's kind of this vague, non-specific thing. But if you look at causes of death from sepsis, you can see that severe sepsis kills more patients than breast cancer, AIDS, and myocardial infarction. But pregnant women, we get away with a lot. Our patients recover. Like an 80-year-old patient who had a lactate of 4.6, like the patient I saw this week, would probably not have survived that insult. My patient didn't even look nearly as sick as her labs made her look. I looked in the computer before I go see the patient, and, I'm expecting to find a patient near death, and, I have to interrupt her breakfast and turn down the TV because she doesn't think there's any she doesn't feel good. She feels like she has the flu, but she's not an extremist like you would expect her. You can guess what all these people have in common. This is Patty Duke. Some of you may have no idea who this is, but I remember who this is. This is Pope John Paul II. This is Jim Henson, the creator of the Muppets, and then I included this guy who I have no idea who he is, but his name is Socrates. So I'm Googling who died of sepsis, and Socrates shows up, and I'm like, how do they know that Socrates died of sepsis? And he's a soccer player in Brazil. But apparently quite a big deal if you're a soccer fan. I had no idea who he was. But all of these people died of complications of sepsis, most of it gut related. Okay, so it happens. This is a very interesting data set looking at pregnant women who were admitted to the hospital and had sepsis during their hospitalization for delivery. Now, what's different about this is that a lot of our data like this looks at death. Okay, so we look at maternal deaths. We don't have a good way to capture maternal morbidity until just the last couple of years where that's improving. But they looked at you're hospitalized for delivery, how many people also had a code for sepsis in there. So this is probably underappreciating it, if anything, but this is the sepsis code. Here's severe sepsis, and they're going up a little bit. They're relatively stable, but look at death. I mean, it just kind of skyrocketed relative to the diagnosis. And this is a similar data set. Jill Meyer is an anesthesiologist who has done an extraordinary amount of work in this arena and has participated on some of the advisory boards who are creating obstetric-specific criteria for sepsis. But she pulled data on cardiac arrest during the hospitalization. And look, sepsis is right up here on the top. When I ask people, why do patients have cardiac arrest? Almost without fail, the first answer I get is what? Why do pregnant women have cardiac arrest in pregnancy? Without looking at this slide, what would you have said? Amniotic fluid embolism. It's what everybody says, right? But it's usually going to be more likely to be due to hemorrhage or sepsis. And amniotic fluid embolism is kind of right up there. These are all the different, anywhere you can get an infection, it can cause sepsis. In pregnant women, it's pneumonia, GU, it can be other things, but you have to think of the uterus. You have to think of the uterus. And usually it's pretty obvious whether or not you need to go there and test them. Now, there's not a lot of studies that provide data on specifics like vital signs and other diagnoses. This was one unique study published a few years ago that actually looked at patients and tried to differentiate between severe sepsis and septic shock. And really the only thing he found was that, septic shock patients were more likely to be hypotensive. Well, this is a shocker because that's the definition of septic shock, okay? Altered mental status, and then organ failure and death. But, really what it shows you is that there's not a lot of difference between severe sepsis and septic shock in terms of how your patients present clinically. And I'm going to come back to that in just a second. Now, I remember when these Sears criteria came out back in the early 2000s, and I was completely confused. Like, I don't understand what this means. It just seems vague, nonspecific. How am I supposed to use this at the bedside with a patient? The idea behind it is that when you have some sort of an insult, and in this case we're talking about infection, your body is going to respond to it. But it doesn't necessarily respond specifically. It responds very generically and like a shotgun blast, trying to just handle everything at once. And you get this massive inflammatory response, which leads to activation of multiple systems, including your clotting cascade, your thrombolysis cascade, and you get these incredible inflammatory mediators like interleukins and tissue factor and all this stuff. And a long time ago, before we could measure all of these things with blood tests and had central lines and stuff, Sir William Osler understood this, that except on few occasions, the patient died from the body's response to the infection rather than from the infection itself, and nothing's different. Okay, it's not the bacteria that kill the patient, it's the patient's response to the bacteria. Think about it. Think about the last patient you had that had positive blood cultures. And then think about the patient before that. Did they have the same clinical presentation? Probably fever. But one may have been hypotensive and tachycardic, and the other one might have been like my last patient who never had hypotension and was only mildly tachycardic, like 100 to 110. Really unremarkable considering the fact that she had positive blood cultures. Whereas the other patient nearly died. Same bug. Same bacteria. So they introduced this fancy sepsis continuum, starting with the inflammatory process, leading on to sepsis, severe sepsis, but this is gone now. You're welcome. I wish I could take personal responsibility, but the bottom line is that it's a nice physiologic concept, but in real life, all you need to know is, are they septic or are they in septic shock, period. So the Surviving Sepsis campaign, you can Google it. They have a website, I think it's called survivingsepsis.org, with unbelievably helpful tools that are completely free, including pocket cards, slide sets, education, order sets, bundles, everything you can imagine. It's an international campaign designed to reduce deaths from sepsis. And about every year, it seems like lately, they're updating their criteria. And so last year, they updated their criteria again and simplified things so that it's either sepsis or septic shock, which makes it much simpler. But some of the data predating this recommendation will muddy this a little bit because they were still kind of collecting information based on sepsis, severe sepsis, septic shock. So their definition of sepsis is kind of vague. Life-threatening organ dysfunction caused by a dysregulated host response to infection. Okay, what does that mean? It means how did the body respond to the infectious agent? Some people it's going to be very mild. If you have a severe response, they're septic. Okay? So in the non-pregnant patient, and I'm going to emphasize that all of this is in the non-pregnant patient, it's any two of the following criteria. So a systolic blood pressure less than 100, respiratory rate greater than 22, or altered mental status. Now, I would argue that labor and delivery is probably the only unit in your hospital where you can have a blood pressure of 90 and a rapid response is not called. Right? So we routinely see blood pressures less than 90, and I will stress that you got to go back to sentence number 1 up here. Response to infection, because people start going bananas when we start talking about using these kind of criteria in pregnant women. Oh, everybody's going to have a sepsis protocol. You know, everybody's going to be diagnosed with sepsis. Well, I would argue that that's not the case, and the data are starting to show it, but it's response to infection. So folks, if you've got a patient who presents in, to rule out labor with triage, she's afebrile, you have no reason to believe she's infected, and her blood pressure is 95, you're not even considering the diagnosis of sepsis. That's not a septic patient. But if the patient comes in complaining of flank pain and has a temperature of 100.4 and a blood pressure of 90, now you're considering sepsis. It doesn't mean she has sepsis, but you need to consider the diagnosis, and I'll talk to you about how you figure that out. Now, this is what is called the bedside Q-SOFA score, the quick SOFA score, and I'll show you what that means. But the idea is in the non-pregnant patients, so you can use this in your GYN patients, in your ONC patients, and all your non-pregnant patients. It's it's recommended and it's easy to use. You can quickly identify whether your patient is at risk for a prolonged ICU stay. Now, mind you, these are ICU patients, most of them. This, I want y'all to memorize this. I'm going to ask you questions at the end. No, this just gives you an idea of where these come from. This is the score, the actual SOFA score, and the other one they just took a few criteria from it. But over here are the different criteria. You've got the respiratory, coagulation, liver, cardiovascular, et cetera, and you get points depending on how bad you are, and you just add them up. Again, you don't need to memorize this. You've got an app or a pocket card or something, but the idea is that the more clinical effects from the infection, the more likely you are to be septic and the sicker you're going to be. The key is recognizing. The hard part is not, okay, guys, sepsis is not hard to treat, but you can't treat it if you don't recognize it. If you don't even recognize the possibility, you're not going to treat it properly. Once you recognize it, the treatment's actually easy. So if they're in the ICU, you're going to use the advanced score. If you've got a patient in the ED or whatever, you're going to use that quick. What's their blood pressure? What's their respiratory rate? And do they have an altered mental status? And if you have a score more than 2, 10% mortality. Now, this is non-pregnant. So it just gives you an idea of how well these things work in the non-pregnant world. Now, septic shock is all of those patients plus essentially hypotension that can't be reversed, or severe lactate level, despite adequate fluid resuscitation. Now, what is lactate? So lactate is a byproduct of anaerobic metabolism. What do I mean by that? When tissues don't have oxygen, then they have to make energy in other ways. Okay, y'all remember the Krebs cycle? Right? There was a reason you had to remember this once upon a time. The idea is that the byproduct of trying to create energy when you don't have oxygen is lactic acid. You have all had elevated lactic acid at some point in time. If you exercised ever and got sore muscles, that's lactic acid buildup in your muscles because the tissues didn't get enough oxygen. This is not in and of itself a dangerous thing. But when you combine it with the setting of infection, it's a sign that you are not delivering oxygen to your tissues adequately, and therefore they're having to function on their own and make lactic acid. So when you draw a lactic acid level on an infected patient and it's normal, what does it tell you? You're oxygenating and perfusing your tissues well. Okay? You don't need a blood gas to figure it out. It's a venous draw, right? If your lactic acid level is elevated, you are not adequately oxygenating tissues. And in the case of sepsis, it's usually because your volume depleted. Could also be because of clots. So shock is because you can't correct their lactate level with adequate fluids, or you can't correct their pressures with adequate fluids and vasopressors. You've seen these patients. They're in the ICU. They're super sick. They're far down the sepsis pathway. Your goal is to never have your patient get there. Now, how do you diagnose this in pregnancy? It's very difficult. It's difficult to use these scores. It's not difficult to diagnose sepsis. It's difficult to use these scores and these triggers. I'm going to give some background as to why this is so difficult. It's only been like in the last probably, 10 years or less that we've even tried to use these scores to predict who's septic and who's going to be sickest in patients. And long story short, this modified early warning score doesn't work. Great concept, but when you look here at the things that are being measured, which are blood pressure, heart rate, respiratory rate, etc., and you get a score for it, your patients are going to have a lot of false positive rates because they haven't been modified to meet pregnancy. SIRS criteria, same thing. The bottom line is that these specific criteria do not work in pregnant women. This is the first score that was introduced. This is called the, I'm going to blank on it, sepsis and OB score. And essentially what they did was they modified things. So you've got all these different scores, and you can have, just like a Bishop score. Okay, you'll never remember any of this. But it's got, you can be hyperthermic or hypothermic, hypertensive, hypotensive, etc. And you add different scores. And it did a better job. This was just published a couple years ago, but the problem is this is a retrospective review. It's not been tested prospectively. All right, okay? So this is where we're at. Now, SIRS is this generic inflammatory response to a bunch of different things. We're looking at infection, right? But it can be from, you name it, anything. Burns, trauma, whatever. You can have an inflammatory type response. And only a small subgroup of patients are going to get septic, and even a smaller subgroup of patients are going to get septic shock. What your goal is, ideally, you're going to treat this group of patients before they ever get here. But if they get here, you're going to recognize it and treat it before they ever get here. Now, remember I said you have this activation of all of these processes from an infectious insult. Well, the bottom three responses are this inflammatory response, which we're very comfortable measuring in the form of white blood cell counts. We generally are not measuring a lot of, IL-6 and TNF and all this other kind of stuff unless you're doing research on sepsis. From a clinical perspective, you're looking at white blood cell counts and what percentage of immature forms in its very simplest state. But a lot of the bad stuff and the morbidity that we see from sepsis and septic shock is not because of this inflammatory response here, it's because of these responses. You get a thrombotic response and a fibrinolytic response. So it's like you've roto-rooted your entire vascular system, okay? And you've got this massive systemic activation of a thrombolytic response, which creates microthrombi, all right? And these microthrombi essentially lodge themselves in the small capillaries of your organs and create hypoxia. So fluid can overcome this to a certain degree. You can just get past these microobstructions. But if you don't give fluids, and you've got these microthrombi in your kidneys and in your extremities and in your lungs and your heart and wherever, then the oxygen delivery problem just gets worse and worse and worse and worse and worse. So now your patient is hypotensive. She's got a blood pressure of 80/40. She's, tachycardic to 130, she's got a temperature to 103, and you haven't adequately fluid resuscitated her. And the first thing you want to do to respond to this low blood pressure, because we're all afraid of fluids, we say, oh my gosh, if we give her fluid, she's going to go into pulmonary edema. You're right, but it's better to be alive with pulmonary edema than dead without it. Okay? You can treat pulmonary edema. But if you don't reverse this process quickly, it's going to end up being ARDS, and you're not going to be able to fix her. So a lot of times our instinct is to do what? Not fluids, but we want to just give vasopressors. You must give fluids before vasopressors. The problem is a lot of times we let patients get so far down the road that we're terrified of them by the time, and they're very sick, and we don't feel like we have time to wait for fluids, and we start pumping them with vasopressors. And then we wonder why we had to amputate a limb. Because you've now vasoconstricted without adequately fluid hydrating. And so you've just made your vasoconstriction and your hypoxia problem worse. You've just worsened your perfusion to your fingers and your toes, and then people start losing limbs. Okay, so fluids first. There's a role for pressors, but guess what? There's a guideline and a protocol that you can follow. Normal lactate is somewhere between 1 and 2. If you get a lactate above 4, like I just saw, you've got extreme tissue hypoxia, and it can lead to organ failure. Miraculously, this patient that I saw had no organ failure. God bless the young and healthy, because, she was just lucky, quite frankly. But a lactate over 4 is pretty significant. Now, the incredible thing was within about 12 hours of many liters of fluids, her lactate was down to 2.9, and the next morning her lactate was 1.5. So within 24 hours, it completely reversed. It's the beauty of fluids. She never got a vasopressor. This is the Surviving Sepsis Campaign website and their most recent guidelines. Again, spend some time on their website. Look and see what tools they have. It's an incredible resource, and it's all free. And they stay very up to date. This is an example of one of their bedside cards, pocket cards that they have. That's the Q SOFA score about how to recognize sepsis and what it looks like, and it's just another resource for you to have. So we're going to think of this in terms of bundles, and this is what they recommend. You've got 2 bundles. Now your job as the non-intensivist is to do a 3-hour resuscitation bundle. Everybody in this room is capable of doing a 3-hour resuscitation bundle. And ideally, this is nurse and EMR driven, so that you aren't allowed to really forget anything. An order set gets implemented when the patient meets certain trigger criteria. And it's very simple. You're going to get blood cultures. You're going to start antibiotics. You're going to draw a lactate, which is the part that we forget as obstetricians. Okay, draw a lactate, and you're going to give them fluids. And then you're going to see what happens from those things to determine your next steps. I'm not going to go through the algorithm and the protocol. I want you to understand principles and concepts, because I guarantee you the recommendations are going to change in 6 months. Okay, you need to stay up to date on that. The point is, you're going to get antibiotics and cultures. You're going to start your blood cultures before antibiotics. You're going to draw a lactate level, and you're going to start giving them fluids. Do not be afraid of pulmonary edema. Do not be afraid of pulmonary edema. I get asked all the time, how long do I have to wait for blood cultures? Okay, because I want to give those antibiotics. Good. Basically, I want you to give the antibiotics within the first hour or less. If you can't get blood cultures in an hour, you've got a bigger problem. Okay, that has to be addressed on a system level. And this is one of the reasons why these sepsis guidelines and protocols have been so helpful, because it's facilitated communication between departments and removed barriers, so that when a protocol or a guideline is initiated, it's like your massive transfusion protocol. Things can just roll downhill. It's much easier to get things accomplished. But culture everything that could possibly be infected, including the uterus. If you need to do an amniocentesis to figure out if it's the uterus, please do. And beyond that first hour, every hour in delay in the non-pregnant patient population increases your mortality by about 5 to 7%. So it's important to be timely, but you do have time to do cultures before you have to start antibiotics. Now you've done your 3-hour bundle, which is fluids, drawing your lactate, cultures, and antibiotics. And then within 6 hours, you're going to be making a decision to start your next bundle within 3 hours, and then you've got 6 hours to accomplish your next bundle. And that's, okay, if you have not been able to correct their low blood pressure, then you're going to start vasopressors. But notice fluids were first. Fluids were first. If it was elevated, you're going to remeasure the lactate. And you're going to keep following it to see that you're making progress and improving your oxygen delivery to your tissues. And you're constantly reassessing volume status and tissue perfusion. Sometimes this requires central lines. A lot of times it requires admission to the ICU. Many times you do your 3-hour bundle and you recheck things and you're done, especially in a pregnant population. You may address the situation right there. Or you got a patient you admit with pyelo. She got a temperature 103. You draw her blood and her lactate's 1.5. Guess what? She's just got pyelo. She's not septic. You haven't given her pulmonary edema with the fluids that you've been doing, waiting for that lactate level to come back. So you haven't caused any harm. This is the art I have in my living room. Not really. But this is what E. coli looks if you look at it under a scanning electron microscope and make color out of it. It's gorgeous, right? I mean, it's just really pretty, except if it's in your blood. This was that same data set I showed you before, and these are the bugs. None of this is a surprise, right? I mean, some weird ones, like I can't remember the last time I saw Serratia anywhere, but gram negatives, E. coli, staph, I mean, this is what we see, right? These are not weird bugs, so it's not hard to pick an antibiotic. I'm a big fan of Amgen and Clinda. There's nothing wrong with Amgen and Clinda. Give whatever antibiotic you choose, as long as you cover most of these. This was published in literature a few years ago, and I just think it's amazing, so I show it. I'm glad she wasn't my patient. There's part of me that like wishes she was my patient because I'm like one of those sick people that likes to take care of really sick people, but part of me is really glad. This patient had a vaginal delivery a 1 week prior. She had a symphysis separation. When was the last time you saw that? Readmitted 1 week postpartum with lower abdominal pain, swelling, and this is what it looked like. This was a picture from their publication. She was treated with antibiotics for cellulitis. Okay? 12 hours later, this is what she looked like. She was in shock. She had multiple surgeries. Amazingly, this patient made a full recovery, and it was probably because they acted so quickly and so fast. But necrotizing fasciitis is a bad, bad, bad actor, and especially that beautiful bug right there is beta hemolytic strep. Flesh-eating bacteria, right? Now, you'll be thrilled to know that the World Health Organization has finally gotten on board, and this year there is a new definition of maternal sepsis. 2017. Total aside, kind of like the United States Public Health Service. Did y'all know? Breaking news. We're supposed to screen for preeclampsia at every prenatal visit. I'm not kidding. This is an official recommendation that just came down. So the World Health Organization has given us a definition that is helpful. I mean, it's nice to have definitions that we can all agree on. A life-threatening condition defined as organ dysfunction resulting from infection during pregnancy, childbirth, post-abortion, or postpartum period. I think we can all agree that this is a reasonable definition, okay? Very similar to what the sepsis campaign described with their definition, but they've added some pregnancy criteria. Now, the real importance of this, I mean, I'm being a little sarcastic, but the real importance of this is that it's creating a focus. It's the World Health Organization recognizing that sepsis in pregnancy and postpartum is a big deal, and they're officially declaring it a problem that they're going to address. So that's the importance of the definition, not that we didn't know what maternal sepsis was, okay? And this year, in fact, this fall, and I couldn't find any specific dates when I looked online to find out, but they are actually launching a huge program to try and attack this problem. I don't know exactly what that's going to entail, but you guys want a simple guideline on how to take care of sepsis? This is it. Infection plus organ dysfunction, identify the cause of infection, treat it, and look at here, point of care, do all this organ assessment, which they don't describe what that means, and then treat it. Now, the Surviving Sepsis campaign gives you specifics. This is quite generic, but this is all they've get. This is the sum total of the data that's been provided. Now, I'll tell you that right now, the SIRS criteria or sepsis triggers specific to pregnant and postpartum women have been proposed, and they're being tested. I mean, this is a hot, hot area right now. Just this year, there were some criteria that were proposed and published. That the problem is that there's been essentially, that I'm aware of, 2 different criteria that have been proposed for pregnant women, and they're different. Okay, so we don't know what the right criteria are for pregnant women. We know they're not the same as for non-pregnant women. We know that the systolic blood pressure needs to be lower than that for non-pregnant patient. We know that the heart rate needs to be higher. We know that the respiratory rate probably needs to be a little bit higher, but we don't know exactly what the right triggers are. Worst case scenario, you implement non-pregnant triggers in your hospital, and you say, we're going to use 90 systolic blood pressure, and we're going to use a heart rate of 110, whatever you choose to use. You're going to overdiagnose some pregnant women with sepsis. And that means you're going to give a few women some extra fluids while you're waiting on a lactate level. That's basically what it means. You're going to draw cultures, you're going to start antibiotics on an already infected patient. The big difference is you're going to draw a lactate level and you're going to start fluids. If they have a normal lactate level, that's valid. They're not septic. You go back to whatever you were going to do for infection. If they've got a positive lactate level, well, you're going to continue down your sepsis pathway. So a few more women, we don't know exactly how many, a few more women are going to get lactate levels and extra fluids until you get those results back. So there's not a lot of harm in, quote, over-treating. But I do believe we need to have more specific, validated maternal triggers so that we know, okay, is 100 the right blood pressure, as has been proposed? Is 120 the right pulse to trigger us, as has been proposed? What's the right respiratory rate? Is it 22? I don't know. I don't know that anybody really knows right now. And that is coming. I think you're going to see something over this year is going to be a big year. The next 5 years, there's going to be tons of information coming out on maternal early warning triggers. Routine sepsis screening. Frankly, this is already happening in many units outside of labor and delivery. Some hospitals have deployed sepsis nurses whose job it is to respond to the EHR's triggers. When a patient has certain triggers, then the sepsis nurse, she's not unit specific, she's hospital specific, or he, and they go evaluate that patient and initiate the protocols if necessary. That's kind of a new trend that we're seeing. Checklists and protocols are already the norm and the standard. If you don't have one in your hospital, it's coming or it's being developed. I mean, it's like the hemorrhage protocol. They're just being rolled out, pretty consistently across the country. And I think what we're going to see as a result is improved maternal morbidity and mortality. Now, the only data that's been published on maternal early warning triggers is not specific to sepsis. Sepsis is bundled in with triggers for hypertension and cardiac disease and everything else. And there are some interesting trends, but nobody's demonstrated convincingly, it's not a hard sell that you're going to make things better, but we're going to have large numbers of patients because our patients actually do pretty well anyway, even when we mess it up. So we have to have lots of patients to show that these things are going to actually work. But I do think the future is going to ultimately mean less deaths and less morbidity from infectious causes. So, key points I want you to leave here with. Please do not explain away abnormal vital signs. My pet peeve is tachycardia. Okay. I challenge any of you to try and maintain a heart rate of 110 for 30 minutes at rest. So the next time you have to go check on a patient who's got a heart rate of 110 and we try to explain it away because she's nervous or she's mad at her boyfriend or whatever it may be, just stop and think. Maybe something else is going on. It's not that easy to maintain tachycardia unless you're actually physically exerting yourself in some way, unless you're sick. There's no single diagnostic test for sepsis, including a lactate level. A lactate level is helpful in the setting of infection where you're suspicious for sepsis, but even a lactate level is not a diagnostic test. It's part of your whole clinical picture. So you have to be suspicious first. Okay? It's like HELLP syndrome. You diagnose HELLP syndrome with lab tests. If you're not suspicious of it, you'll never diagnose HELLP syndrome unless you do labs. You have to have the trigger to do the labs. And early recognition and treatment are absolutely key, as with most things. And in this one, we actually have an opportunity to recognize and treat and prevent. Some things we don't. Preeclampsia, Not a lot I can do. I can deal with the consequences when it actually happens. I can't necessarily prevent it from happening. I can try, I can give some aspirin, but sepsis, I can prevent infection from leading to sepsis, and I can prevent sepsis from getting to septic shock in the majority of patients, if I'm proactive and I recognize it. So with that, we're going to I left some time for questions.
I wonder if you would comment, you had mentioned about source reduction, getting rid of the source of the temperature. Of the difficulty, you have a revival fetus that's dead.
Yes.
23 weeks it's dead. Months septic from chorioamnionitis, ruptured membranes. And you try to induce these people, it's not always a nice, easy induction. At what point is D&E a desirable option as they are, temps of 102 and 103, pulses in the 130s? Okay. When is D&E versus just keeping it inside the tank, is it a good thing to do?
Great question. So that question, I'll just repeat it in case you have a wonderful voice, but I don't know if everybody heard you. But, a fetal demise, 22 to 24 weeks, patient is septic, febrile, and you've got to make a decision about, medical induction versus a surgical procedure to do source control and empty the uterus. Because ultimately emptying the uterus is essential to getting this patient to turn around. Well, first of all, most of the time, when the baby's already passed and it's infected, the delivery is relatively quick. And in my recommendation, I avoid a surgical procedure on these patients unless I really feel it is the absolute only way to get them to turn around and my medical induction has failed. Because
Specific example, it was like 18 hours worth of side effect and there was no delivery.
those are the patients that I would put a Foley bulb in, do some sort of manual dilation, primarily because operating on an infected uterus is not a great idea. I mean, it's doable. You can do it, but you may end up making her worse, and you have to be prepared for that. You can seed her, she can get a showering of bacteria from your surgical procedure, but I would try some manual process to open the uterus, or even, we used to do hypertonic saline injections into the amniotic fluid to get them to deliver quickly. I avoid surgical procedures unless I really feel like they're unavoidable. 18 hours, I'd still keep going unless she is not making improvement. If I can't keep her well, if I can't keep her resuscitated, and I can't wait anymore, then you may not have a choice. I had a patient, I saw you, David. I have a patient where I was called to consult on the patient for preterm labor. Okay? She was about 26, 27 weeks gestation. She was admitted with abdominal pain. She was contracting. She was 1 centimeter dilated. And when she was admitted, she was afebrile. Less appetite, didn't feel great, but nothing very specific, nothing very exciting. Her white count was like 18,000, but they'd just given her some steroids. They weren't sure what was going on. 24 hours later, she's still contracting. They're not sure what to do, so I get consulted. I go see the patient. Patient is, blood pressure was about 90/50. Her pulse was in the 120s. Her white count had gone up to about 22, 23 at that point with the left shift. Her abdomen was tender, but it was not her uterus. Patient had an appendiceal abscess that was smoldering. They'd given her group B strep prophylaxis, and she didn't look toxic. She wasn't terribly impressive, except that this patient was clearly septic. Over the next couple of hours, she started to deteriorate. I moved her to the ICU. We hydrated her. I ended up having to put her on norepinephrine. She was about 26 weeks gestation at that point. Baby looked fine on the monitor. And we took her to the operating room. I assisted the surgeon. The surgeon did the laparoscopic appendectomy and, got rid of the abscess. And ultimately, even though this patient had appendiceal abscess, septic shock, norepinephrine, 26 weeks gestation, the patient went home pregnant. Carried to term. Just because you're looking at a uterus does not mean you have to cut it. All right? The last thing a patient like this needs is a delivery. Now, if you truly believe you have to do delivery to save the patient's life, you have to do the delivery. But most of the time, treating the infection is going to reverse the process. And if not, you can always go back and deliver the baby if you need to. Okay? Devin?
Just come out and test the case. Tiffany and I have done these in the past where we've done intra-amniotic hemobaby, 10 vials.
Yeah.
It's very easy if the sac's intact. If they're ruptured, it's a little bit more tricky, but
Right.
that's another trick that you can try
Yeah.
to get them delivered faster?
Yeah, it's unusual for them to not deliver in that time frame if it's truly the uterus that's infected, and especially if the baby's passed. So my general recommendation is try vaginal delivery first, because not doing surgery is always safer on a septic shock patient than doing surgery. So if you can avoid a surgical procedure, great. If your patient is deteriorating and you don't have time to wait for that, then you're kind of between a rock and a hard place about what to do.
I'm gonna let her ask her question.
Okay.
Not ask mine. My question was about how far into management do you use SVO2?
So how far into management do you use SVO2? So there's actually, that's part of the protocol. SVO2 is your measurement of oxygen delivery to the tissue level, and you have to have central line. So central line guided therapy is part of the protocol. So if you have a patient who's requiring pressors, you've got central lines in. So anybody who needs a central line, and many of these patients do, then you're going to start doing your SVO2 monitoring. But there are protocols for not doing it as well. You don't have to do central lines on these patients. You don't have to do SVO2 monitoring. There's a very specific part of the goal-directed therapy guideline that says, okay, if you've reached these targets, you're good. If you haven't, then you're going to circle back around and start doing this, and much of it will require a central line. Yeah.
Can you comment on intermittent versus continuous fetal monitoring in the ICU?
Intermittent versus continuous fetal monitoring in the ICU. Don't ask the question if you don't want to know the answer. If you don't want to know the fetal condition, do not monitor your patient. Meaning, if you are not prepared to do an emergency delivery, do not monitor the patient. That's the bottom line. So recognizing that the baby could significantly be compromised, but if your patient can't be delivered, your baby's pre-viable, whatever the situation, if you aren't prepared to deliver that patient, you should not be monitoring. If you choose to monitor the patient, which most of us do if you've got a viable baby, if you choose to monitor the patient, you must have a delivery plan that is well communicated. And I have met very few ICU nurses and doctors who are happy to see a warmer in the adult ICU. They do not want to see a baby warmer up there. Okay? I've done sections in the ICU. They can be done. It can be just like an operating room if you need it to be, but that's not the ideal situation. You want to have a plan. What are we going to do if baby deteriorates? Are we doing the section here? Are we taking her to the OR? Which OR? In what time frame do we expect to have this accomplished? You have to have all of that plan mapped out, and it's going to depend on gestational age, estimated weight, mom's condition, et cetera, et cetera. I have had a situation recently where we chose not to monitor the baby and allowed the baby to pass because mom was too critically ill and baby was too questionably viable to consider compromising maternal condition for a questionable neonatal outcome. And that was a family and a multidisciplinary decision. That was not a unilateral, Dr. Martin decided this is how it's going to be. That's a huge conversation, as you can imagine. That answer the question? I think part two of this, well, there's no guideline, there's no protocol. This is where you have to have a team conversation about why are we monitoring? What's our goal? Okay? And sometimes it's to optimize oxygen delivery to the fetus just to maximize outcome, even if you're not prepared to do an emergency delivery. The fetal heart rate monitor is a central line. I mean, it's like a Swan-Ganz. Okay? If your baby is reactive and not tachycardic, guess what? Your uterine perfusion is fantastic. But as mom becomes sicker and more hypotensive, she's going to start shunting blood away from non-essential organs. And intestines and uterus are non-essential organs in the body's hierarchy. So blood is going to start being shunted away, and you will see it. And they start contracting, both because they're volume depleted and the uterus is not getting perfusion. And you'll start seeing lates and, fetal compromise, whatever that means. But it all reflects inadequate perfusion and oxygen delivery related to her clinical condition. And that's common. I think the bigger question, in my mind, is where should the patient be? Should the patient be in an ICU with a fetal heart rate monitor a mile away from labor and delivery and anybody who's comfortable with the uterus? Or should the patient be on labor and delivery with nurses who are capable of doing both? I'm a big fan of the latter under the right conditions. Okay, I'm going to tell y'all a true story about this was at one of the hospitals where Garrett and I used to work, and I always try and forge relationships with the ICU team at the hospitals where I work, because I just love ICUs and all this stuff. And this was one of the very first times I'd worked at this hospital and had it was the very first ICU patient I'd had up there, and I just met the team and was building relationships, and they were awesome. They were so excited to help me take care of our patients. And so I had this patient up in the ICU. This was back in the days of pagers. Okay, so y'all have pagers? Wow, holy moly, that's like jewelry. What's that? Yeah, I haven't had a pager in years. So anyway, we had pagers, and I get a 911 page to the ICU. Now, a 911 page to the ICU is no joke. I don't even bother to answer the call. I just start running to the ICU. I run up to the ICU. I barrel through the doors. I'm out of breath. Oh my God, where is she? Where is she? And there's this crowd around my patient's room, and it's silent. Like, it's just silent. There's no chaos. There's no, and I'm thinking, she's dead. She's already dead. They've coded her. She's died. Oh my gosh, like this, how could this, my first patient in the ICU, how could she die? Like, I walk in and she's not dead. And they're literally standing there staring. There must have been 10 people standing around her bed staring at her. No joke. I walk up and I'm like, oh, the nurse is like, oh, Dr. Martin, you're here. We're so glad you're here. She pulls me aside. She comes over to this. She says, we think her uterus fell out. She was serious. They were terrified. No one was touching her. They didn't know what to do. And I was like, oh, okay. Well, I've seen that. Okay, let's go look. I pull back the sheet. Massive labial edema. The kind of edema where they're translucent and kind of laying on the bed. They'd never seen it before. They didn't know what it was. They thought her uterus had fallen out. This was a 911 call, people. Okay? Now, the point of that story is not to belittle the skills or the experience. It's the fact that ICU teams do not have your experience. Okay? And pregnant and postpartum women are frightening to people if they don't have the experience. You guys are not afraid of it. You OB folks in the room are not afraid of it. But you go into an ICU, and that's very intimidating. But that's their home. So somehow we have to marry these two, right? So that you've got ICU teams that are comfortable taking care of pregnant women and OB teams who are not afraid of a critical care woman. Okay, so we all have to have some sort of, melding together so we can take care of these patients together. So I think a better answer to your question is, where is the better place for the patient if we're going to monitor her? Is she going to be up on labor and delivery with a warmer there and a perimortem section kit? Or are we going to have her closer to where everybody's comfortable taking care of the pregnant woman, and we can deal with her critical care needs as well? Thank you.
So Dr. Martin's around for the next hour. We're going to do a meet